So it's my pleasure this evening to introduce our guest speaker. And the speaker is Dr. Jeff McCracken. He was born in Victoria. He practices his urology here. He received his medical education at the University of Victoria, UBC in Vancouver. He went to Seattle for a fellowship in radical prostatectomy, robotic surgery. He has now been practicing here in Victoria for 10 years. He has a special interest in prostate and kidney cancer. And he's also interested in minimal invasive surgery. I think most of us would be highly interested in that. We are most grateful to Dr. McCracken, as he's been a presenter here a few times over a number of years. I can say for myself, when I was first diagnosed, I guess 9-10 years ago, I was referred to Dr. McCracken for a second opinion, so I have some personal experience with it myself. I'm grateful that he's still coming to present to us. When he's not working, can't imagine when that is, he has several young children at home, which must take a lot of your time. So his topic for tonight is a review of the state-of-the-art diagnostics and treatment strategies for prostate cancer in the new age of PET and CT technology and targeted drugs. So please join me in welcoming Dr. McCracken.
Well, thanks everybody. It's great to be back. I have had quite a few patients come through my office saying that they've seen the YouTube videos of previous talks. And I hope not a lot of people have seen it, because I did adopt some slides from the last talk I gave. Just because it was a little bit of a sort of stream of consciousness about prostate cancer that touches on everything. And so I've updated it, to the sort of modern era of prostate cancer treatment. And I tell you, I don't think I've ever seen a time in prostate cancer. I've been studying and researching prostate cancer and treating it and whatnot for almost 20 years now, and I don't think I've seen such a rapid change as I've seen in the last year. So if any of you guys, and I know some of you are dealing with prostate cancer or the after effects of treatment, I guess it couldn't be a better time to be dealing with this problem, because the horizon is looking really good. And what I learned from watching the YouTube video from 2 years ago, which was almost 2 years to the day, is that I think that I need to get my hair cut. Every time I come here, it's like I'm due for a haircut, so I apologize for that. Was anybody here 2 years ago when I gave a talk? Can you recall that? There's a few people. Okay. Yeah, so I mean, it might be kind of neat to see sort of how it's been updated since then, because I'm always trying to grab onto the latest thing. And towards the end of the talk, we're going to talk about some of the newer things. So the beginning is sort of just a framework. Towards the end, we'll get a little bit more into the exciting stuff. And I'm going to move along through the earlier part to try to get there so we can talk about it. A lot of the stuff that's on the horizon right now, I don't have a lot of experience. One of the treatments isn't really available in Canada at this time. But I can certainly talk to you about the research and literature and stuff that is surrounding it. So I'm also have to admit that I've got a crink in my neck, and I'm going to be looking back a lot. And this is one of the things that happens when you get in your 40s, is you wake up with an injury. It happens while you sleep, so that's great. But I'll be back and forth here, so if anyone misses something, this mic seems like it's pretty good for picking things up. But if you don't hear something, put up your hand. If you guys have questions at any time during the talk, put up your hand or holler at me, and we'll take a break. Answer the question, I'll repeat it so we can hear it on the recording, and we'll make sure that the questions get answered along the way. As well as at the end, I'll stick around for the break, so if anyone has personal questions or things they want to run by me, just holler at me. So the first thing I want to always talk about is prostate cancer and what I call McCracken stages. It's a little bit self-aggrandizing, but I don't understand staging systems, because I think they're a lot simpler than they're made out to be. Prostate MRI is still a big topic. Last time I gave this talk 2 years ago, it was kind of a hot topic, but it still is very important in our strategies for both diagnosing prostate cancer, staging prostate cancer, and assessing treatment of prostate cancer. And then the exciting thing about new therapies, I'll talk a little bit about the drugs. You guys have probably heard about a lot of those drugs, but PSMA is really the horizon that I'm kind of alluding to. PSMA is a really interesting technology. It has a lot of utility. It's changed some of the ways that we deal with prostate cancer, particularly in the recurrent group, and now in the resistant to androgen deprivation therapy group. And lutetium treatment is something that's not available in Canada yet, but we're hoping will be soon. And I'm already sending patients to Australia, which is sort of the closest place where they're doing it. So we'll get into that towards the end. So this is a rehash of some old slides here, but this is Mr. Worst Case Scenario. And this takes a little bit of, I'm sure, a lot of people's stories about, how things have gone, how the diagnosis has come to be, and then some of the complications that can go along with the diagnosis and treatment. The story, I use this scenario of about a 65-year-old man, if I'm talking about prostate cancer, that's probably on the younger side, but close to average for the diagnostic crowd. These are the guys that often are getting screened a little bit more often than the younger crowd. And the older crowd, there's controversy as to exactly how much screening should be done. But 65 is in the safe zone. These are the men that often will benefit from being identified as having prostate cancer. The story starts out with he's got some urinary symptoms. He has a PSA test done, and it's kind of sitting in the sort of middle high range at 5. Found to have some prostate enlargement. Started on this drug, dutasteride, a generic drug that used to be called abiraterone. Now it's pretty much all generic. And that is a drug that shrinks the prostate. It alleviates urinary symptoms usually over the course of about 6 months. But another thing it does is it should lower your PSA by about 50%. And for some men with really high PSAs, when they come to my office, if it's 10 or 12 or something, and I just don't buy it that they've got prostate cancer, we'll often consider using this drug just to see if we can get the PSA number down really low and if it'll stay there, particularly if there's urinary symptoms, because you'll get the side benefit. Now this guy goes on this medication, we expect his PSA to go down, and when his family doctor rechecks, it's actually gone up. And that's actually a pretty sensitive test for identifying prostate cancer. It's quite specific as well. If you don't respond to that drug, it could be indicative of an issue. He gets sent to the urologist, and like I say, when urologists do prostate exams, sometimes you'll hear something completely different than your family doctor says, because we're just sitting there all day doing prostate exams after prostate exams, so it gives us a bit of an unfair advantage. But the urologist is going to identify some nodularity there. PSA hasn't come down, so we're going to suggest this guy gets a biopsy. So the biopsy, uncomplicated, gets it done, 12 cores done, which is pretty standard for what we do, and they'll come back negative. But the urologist doesn't believe that that's right. There's still suspicion that there's a problem. So what do we do when we get a negative biopsy and there's still indication of some suspicious lesion there or the PSA is misbehaving? We now get an MRI, and that's pretty standard. And sometimes we'll even get the MRI before the biopsy now if we're worried that we can't feel something or we need a target. And realistically, soon enough, the standard of care for just about anybody that comes in the door for prostate cancer screening is that they're probably going to get an MRI. In some people, we see that this lesion where the suspicious area is on the anterior surface. The rectum is sitting back here. This is the prostate. It's got this sort of, I call it the acorn or the chestnut shape. And when we do prostate biopsies, typically using a rectal probe, we're working in this plane back here. And the needles, typically, if you look at a flat plane like that, the needles are going like this. So getting to the front surface of the prostate is a very acute angle. And the urethra, which is where you pee, that runs through there as well, so we don't like to get in there just because we can cause trauma and we can have more blood in the urine and stuff afterwards. And it also, most prostate cancers live in the sort of peripheral zone where it's close to the rectum. So these are the ones that we typically would miss, like especially, because 10 years ago, you could live for a long time with this thing getting bigger, your PSA going 10, 15, 20, as this lesion grew, without, you could have 5, 10 biopsies sometimes that wouldn't show it. And now we can see where it is, and we can actually use a computer to monitor where the needle tract is going when we do this, superimposing the ultrasound on top of the MRI, so we can see on the MRI where the dark spot is, and we can actually see on the ultrasound now where the dark spot is on the MRI on the actual ultrasound, which is in real time. and we can make sure that the needle's going to the right place. So this has been a huge difference for us with identifying prostate cancer. And where this translates into kind of chaos is when you look at screening tests and PSA tests, and there's, as you guys know, I'm sure, there's this huge controversy over prostate cancer screening and PSA testing. And they say, well, if you do PSA testing, all these people are getting unnecessary biopsies, and a lot of people with bad cancers don't get diagnosed despite having had a biopsy. And I think that this technology argues for PSA testing because it's flagging people, and now we can sort of stratify them into their risk category, and if they have bad disease, we can identify it. And part of the reason that the PSA data was so controversial is because even when you were identified with having an abnormal PSA, we still struggled to find the disease at times. So this has been a huge difference, and fusion biopsies are very accurate. If we don't find something on a fusion biopsy, we usually will acknowledge the fact that we don't think you have prostate cancer. There's other types of prostate cancer that don't necessarily show up on MRI. No technology is flawless, but these are the ones that were really difficult to figure out now, and we're getting them routinely. Does that make sense for everybody? Yes?
I've heard some pretty alarming figures for the fatality rate of the biopsy itself.
Yeah.
Do you have any numbers for that?
There's been one fatality in British Columbia in the last 20 years. Yeah. And there was one of the studies that looked at the utility of PSA testing. It was called the OPRO study, I think. It was out of San Francisco. And there was 2 deaths in the biopsy group. And this was a study that was looking at screening versus not screening. And this is what the US task force basically made their recommendations based on the fact that these 2 people had died like right off the bat from screening related problems. Subsequently, that study was shown to have been completely contaminated. So where they were comparing people that were getting annual PSA tests to people that were supposed to not be getting PSA tests, these people had their own family doctors that weren't part of the study that were screening them, and almost 90% of the people in the control group were still getting PSA tests done. So it was a study that looked at basically annual screening versus ad hoc or individual screening.
It's
So
not as alarming.
no, and the key with preventing biopsy-related complications is to make sure people know that if they get symptoms of fever or chills, because it's going to be an infectious-related issue, right, that they go straight to the emergency room and get blood drawn. Like, you can't go to a clinic or the neurologist's office or whatever. You have to go to the emergency room because they need blood, and they need to send it off to see what the sensitivities are. And we have drugs that are very effective, like ertapenem is an antibiotic that's effective for just about everybody that walks in the door with a biopsy-related complications. So the issues come from people trying to tough it out at home for a week and then show up to the emergency room and get the wrong antibiotic, for another few days, and the infections just get out of control. Any other questions?
I understand your neck issue, but could you swing around this way?
Oh, can talk this way a little bit? Sure. Yes?
If the MRI is so successful at identifying this, why would you need the biopsy?
It's a good question. I mean, I don't know when that time will come that we can identify it.
Is it more expensive? Is that why?
MRI versus biopsy? I don't think so. I think that they're roughly equivalent cost. Yeah. I mean, perhaps the capital cost involved in a biopsy or in an MRI is significant, but we have capital costs involved in the ultrasound probes and the disposable needles and all that kind of stuff as well. But typically with any cancer, there's a sort of saying that they say is no meat, no heat. So you don't radiate a tumor that you don't have tissue from. And that's just a sort of principle for pretty much any cancers. We never accept radiology results as being enough to warrant a treatment that could have pretty significant side effects on. We have to have confirmation. The other thing is that there are different histologies, so if you don't know that the tumor type, especially in the age of immunotherapy and things that are to come, if you don't have that initial tumor type, you may be excluded from treatment down the road, especially if there's some experimental treatment that comes out and they say, well, this is only for people that have such and such a type of tumor. Well, if you never knew what type it was before you radiated it or something like that, you might not be a candidate. So I always, even in patients that show up, say your PSA is 5,000 and there's bony involvement and, a really impressive amount of disease that's obvious, I still get tissue from those guys because otherwise you never know what kind of things you'll be excluded from in the future. Any other questions? Okay, I'll try turning this way. Prostate MRI is about a 45-minute procedure. We're changing, I shouldn't say we are, I'm not part of the radiology department, but we've had discussions about changing the protocol to speed it up. Because 45 minutes in this small tube that you can see here can be a little bit claustrophobic. I'm sure people have been there already. And it's a pretty long time, and because of that, it actually cuts the throughput down, and we're really begging for more access to this kind of treatment, or this kind of diagnostic test. So the plan will be to hopefully shorten the exam. It may be slightly less sensitive, but we can hopefully get more people through, and the experience will be a little bit easier on people. Some people require a bit of sedation to get into that machine. It's quite loud as well, so it can be difficult. This is the fusion biopsy. Here you can see, here's a computer-generated image that shows the tumor on the prostate, and it shows where all the needle passes have gone there. So you could be quite convinced that the needles actually pass through the tumor itself. And here you see, this is an ultrasound image where you don't really get the resolution that you do on the MRI. This isn't great resolution either just because of the screen, but here's the dark spot. And if you're just doing an ultrasound alone, you wouldn't see that dark spot. So it's very helpful for that reason. So this guy has the fusion biopsy done, and he gets his diagnosis of Gleason 7. It's a small volume prostate cancer, so it's only like 2 cores out of the 4 cores. When they do fusion biopsies, they usually target just the lesion that they see, and they often will do just 4 cores of that area, sometimes more if they feel like they're not totally certain where the interface is between the tumor and the prostate. And this guy's PSA stable. He's sort of flattened out at 7.5 on Avidart. And his wife's dealing with some medical issues. I hear this quite often, that there's priorities out there, and so we're going to sort of hold off on dealing with prostate cancer. Now, for most people, that's not an issue because prostate cancer is a disease that we sort of say usually has windows of about a decade from the time that the disease starts to the time that it can spread or do something more significant. That is an average, and there's definitely a bell curve that sits on either side of that of cancers that move quicker and cancers that move slower. But I kind of think about the 10-year window, and for a lot of people, they're at the beginning of those 10 years. Some people were catching them towards the end of those 10 years, so there may not be that much time. But usually a matter of weeks or months or that type of thing is not going to factor into the long-term chance of cure or the prognosis. One thing to note is that if you have a PSA of 7.5 and you're routinely taking dutasteride, which is supposed to reduce your PSA by 50%, you actually multiply it by 2. So this guy's PSA is 15, and that's pretty high for a guy that you're going to put on surveillance. But we can't control all the different variables, and so we'll sort of accept what patients will accept it sometimes. So active surveillance is something that I'm sure people here have had experience with. There's different protocols that are out there. The protocol that's most commonly used for PSA testing is that you check it about every 3 months. And usually within the first year you get a repeat biopsy. Now MRI has superseded biopsy a lot for this. We're actually using MRIs at least once after the diagnosis of prostate cancer if you haven't had it done before. And I will usually precede any future biopsies by doing another MRI before they happen. So the MRIs have become a big part of this. And this slide I didn't adjust from 2 years ago where I was saying, well, maybe MRIs. Well, definitely MRIs now. We use them a whole lot. Now, not every prostate cancer can be seen well on MRI, so it doesn't always help a whole lot, but for most people that are going to have advancing prostate cancer or something that's more significant than just the sort of scattered amount of low volume disease, we're going to see it on the MRI eventually when it gets more substantial. So 3 months later, this is the first 3-month interval of this guy's period of active surveillance. His PSA has gone up to 10.5. This is concerning because now this PSA is actually 21 and it's changed. It's actually gone up when you look back and when he started the dutasteride. It's pretty much doubled since then, and that's an indication of advancing disease. So the patient wants to get an MRI right away. Our ability to get MRIs in the hospital here are limited. So sometimes we'll use the clinic at West Coast Medical Imaging at Uptown, where they can usually get you done within a couple of weeks. It varies, sometimes it's tomorrow, sometimes it's about a month out. But people pay about $1,000 to go there. It is a sort of better machine than what we actually have access to here. So the way that MRIs work is that every time there's a new generation of machines, they sort of have double the resolution or double the size of the magnet, which sort of correlates with the resolution imaging. So the MRI or the magnet at Uptown is 3 Tesla, which is pretty much state of the art. I think there's some bigger ones now, but for what we ever see around here, that's about as good as it gets. The ones in the hospital here are 1.5 Tesla, so there's a degree of resolution that we lack in the public system here. I understand they have those, they're going to upgrade the systems here, it's just there's a lot of logistics involved in it because the magnet's so big. Can't be dragging people with their IV poles down the hallway or something. I'm guessing. But yeah, if anyone is looking for an MRI and doesn't want to wait, the West Coast Medical Imaging is a slightly better study and it's a little bit quicker to get usually. So the repeat MRI, so now we're using MRI for staging, not just for screening. And this is now showing that there's a lesion that's sort of abutting the edge of the prostate. So this is a different view. This is like the patient standing facing us and you're seeing right through the middle of them. Bladder's here, prostate's here. Sorry, I'm excluding you guys. And you can see, I'll move over here, that where the arrow is pointing, there's another dark spot there. And this dark spot's right on the corner of the prostate. You can see the sort of flowery seminal vesicles going out behind there. And this is indicative of a prostate cancer that's likely extending outside of the capsule of the prostate. There's no sign of lymph nodes on there that you can see, and sometimes you can actually see lymph node involvement. Because this guy's corrected PSAs over 20, lymph node involvement is possible. It's probably 30 to 40% likely, but not seeing it there. And this kind of illustrates my point about staging. There's really only 2 stages to prostate cancer as far as I'm concerned. If surgery fixes it, that's stage 1. If surgery doesn't fix it, that's stage 2. Radiation or whatever, radiation gets a little bit complicated because sometimes the radiation works around the edges and it might have a sort of like a broader paintbrush when you go in there with radiation. You know, so some more advanced disease may get treated more effectively by radiation because it doesn't just treat the prostate. But that's really the crux of it. Now, it can be that you take the prostate out and there's disease that's sort of extended outside of the prostate locally that's still there, or it can be spread. And if it's spread, it's into the lymph nodes or into the bone or wherever it wants to go. There is a sort of intermediary stage there where you could have prostate cancer that's spread just in the pelvis. So you have the prostate out and the PSA is still there, and then you get radiation to that area, and that seems to seal it off. But if it's gone above the field of radiation, you're going to find out about it because your PSA is going to start going up eventually. We have these tests, the bone scan and the CAT scan, but none of them really can pick up early stage spread. And that's something that's been lacking in our prostate cancer knowledge book. And this is, again, something that we're going to cover at the end because PET scanning may be the sort of silver bullet that we've been looking for to try to help with that staging. So these are the original stages, stage 1 to 4. People say, oh, do I have stage 4 cancer? And I'm saying, no, like we'll deal with the prostate and then see what happens, and then we'll know what stage you're really at. But most of the imaging tests aren't really going to nail down unless it's really obvious that they're spread. And that's been difficult because we don't really want to go in and do a big surgery like, say, prostate removal when there's a really high likelihood of bone involvement or something like that, but we just can't pick it up. So the questions that this patient has are basically, I've got some local extension of the disease but no lymph nodes. Will local treatment cure my disease? And I always think of radical prostatectomy and brachytherapy as being roughly equivalent because they're really just going after the prostate. We're not covering area around the prostate or outside of the prostate. So it's really just a prostate treatment per se. So how do you know that it's localized? Well, it's like a push a button, you're going to get a bone scan and a CAT scan. Prostate MRI gives you kind of local data as to where the cancer is extended. And as a surgeon, it's been very helpful to have MRI imaging because we can use it as a roadmap when we do surgery. We can go wider here or closer to the prostate to spare nerves on this area because we know there's no disease there. And before it was like a black box. We just have the biopsy report that was sort of like apex, middle, and base. Now we have these detailed images as to exactly where on the prostate the tumor is, which is very helpful. And if you look at the risk of having something like positive margins, where when you take the prostate out, they dip it in ink. If there's cancer touching ink, there's a problem. We don't want that. We want to have coverage over the tumor. The MRIs have helped us drop those rates dramatically where there's margin problems. And then, after local treatment, my PSA is still going up, so what's going on? And I say, well, there's sort of 3 different spots. Either it can be in the area around the prostate, it can be somewhere else in your body, or it can be both. And this has, again, been a big struggle for us to identify this, because PSA is so sensitive at telling us that there's a problem or a disease somewhere. It's way more sensitive than any imaging test that we have or that we can use. So you can see in this illustration here of the different stages of prostate cancer. You have T1, which basically means your PSA was elevated, there was no finding on your prostate exam, and the disease is basically just microscopic. It's found on a biopsy just because of your PSA. T2 means there's a lump there. Usually you're going to have a PSA thing that finds the lump and thusly, but T2 means basically there's something there to feel. T3 means that it's extending outside of the prostate somewhere, and if it's into the seminal vesicle, which is adjacent to prostate, that basically is T3b. The significance of this is that when you get to the stage T3b, the likelihood of lymph node involvement actually goes up quite substantially. And T4 is where prostate cancer becomes usually unresectable. Like you don't want to go in there and remove part of the rectum or a large portion of the bladder that's going to leave the bladder with minimal function, because treatments like radiation may be more effective in that circumstance. So our patient decides to have a prostatectomy, and the good news is we have the MRI technology that shows us where the disease is. But we find out that not only does he have capsular extension, so I think of the prostate's like wrapped in cellophane, and the cancer has perforated the cellophane somewhere, but it's going into the seminal vesicles. And despite our best efforts to try to get around it all, they're saying that we can see tumor abutting the ink that's on the prostate. So the patient has an unremarkable recovery at this point in time, and we say, well, we don't know that the cancer is going beyond the ink, we just know it's there, so we'll have to keep a close eye on things. And his postoperative PSAs, thankfully, are undetectable. So at this stage, we're happy, and of course it makes sense that a negative bone scan, a negative CT scan, well, we don't really anticipate any problems. But a year later, we start to see the PSA go up. And it's at 0.05, and then 0.1 and 0.2. And so we can see, based on this pattern, that we're seeing a doubling time about every 6 months. And you can actually draw that line out pretty accurately going forward if you just sat there and watched it. So the doubling time usually is pretty accurate if you're having a problem and you think it's related to prostate cancer. Now, if this number went up to 0.05, and then at 18 months it was 0.06, in 24 months it was 0.07, and really wasn't moving a whole lot, you'd wonder maybe there's a bit of prostate tissue that's still in the area and it may flatten out and not actually cause problems. But as soon as you get about 3 measurements and they're all going up sequentially, and you can kind of look at them and say, it looks like it's doubling this often, usually that's more indicative of a problem. So it's a bit of a language that speaks to us and it's open to interpretation. But this guy, I would say, is high risk for having a problem in the first place. And to me, this is telling me that there's a problem. So, yeah.
What happens if it goes up and then in the next test it goes down quite a bit?
Yeah, well, that's one of the frustrations that we have interpreting it to some degree. And when that happens, you basically do nothing. You just wait and see what it does. And you may have to expand the interval that you're looking at it over and just realize instead of it being a linear thing, it's a scatter plot. But you may have a combination of issues in that circumstance too, right? There may be a bit of residual prostate tissue that's sort of, when you look at the prostate glands at the bladder, it's not like there's prostate here and there's bladder here, and we just cut through the middle. We try to, it's sometimes not obvious, where that line is, and the prostate glands can dovetail into the bladder neck tissue. So you may have little prostate glands that are kind of right at the tip of where the division was, that with time, they're subject to problems like BPH, benign enlargement of the prostate. Those glands may grow, and you may see this sort of fluctuant number, or you may even see the number go up substantially in this plateau. But once you see a pattern, and the pattern involves a pretty reliable doubling time, that's where I'd be more concerned about it. Any other questions?
But
Yeah.
does it matter what time of day you take the PSA? So, like, if you took it, you got, in this case, the person had 7.5 in this meeting, you took that in the morning, and then 3 months later, you took it in the late afternoon. Does that affect the PSA at all?
Not to the best of my knowledge. Like, I don't know of any studies that have really looked at that. Some tests, like testosterone testing, for instance, aside from if you're on treatment for prostate cancer that involves manipulating your testosterone, but if you're just trying to check a normal physiological testosterone, you should check that first thing in the morning, because that's when the number is least variable. But PSA testing, there's no association with that, unless perhaps you did some activity like bike riding, and you biked all day and then you went to the lab at the night. That wouldn't make a lot of sense. But yeah, there's no real guidelines on that, and there's no real evidence that I'm aware of that makes a difference. Yeah. So this gentleman has a PSA recurrence, and we think that it's legitimate. So we are going to repeat an MRI, and this is actually a little bit old because we don't typically use MRI in the circumstance as much anymore. We'll get into why. But this is again a slide from 2 years ago where we were hoping this would be, the be all and end all to us telling or finding out where these problems are. This is a really subtle thing, but there's a little mass in the bladder here that's sitting on the posterior wall. And if you had a really difficult margin in that area and then you saw that, you'd think there might be prostate cancer in that area. That'd be pretty difficult to treat. You'd probably be looking at treating that with radiation if you had to. You can see here now, this is an abbreviation of the MRI. And this was what we were kind of hoping was going to turn into, where you could actually get hot spots and see the tumor. You can see here, this has got a rectal coil, this perfectly round structure behind there. There was a special probe that they had for a while with MRIs that looked like they might be doing this kind of thing, but we've moved on since then as well. We'll get into what we've moved on to in a bit. So we talked about doubling time. Now, with respect to radiation in the sort of, I keep giving this lecture with this horizon on the other side of it, but for a long period of time, what we're doing is sort of saying, well, if you're going to get radiation done after you've had a prostatectomy, the sooner is probably better. You don't want to wait too long. And the range of PSAs that were associated with the suggestion to go get radiation were between about 0.2 and 0.5. There was a study going on here for a period of time where we just would see, T3B positive margins, go get radiation, and don't even wait. And there was some thought that just doing it right off the bat was helpful. But the over-treatment rate was very substantial doing that. And if you can avoid the extra radiation, especially early after surgery, you'll have a slightly better recovery than if you're putting that into the middle of it all. So traditionally, we've been looking at radiation therapy before a PSA of 0.5. And in a guy like this where you say, there's extra prostatic extension with margins and all these other things that put you at high risk for pelvic recurrence, you might send him as soon as you start to see that PSA go up. So you can observe it, you can radiate it, you can use hormone therapy, and again, for a while, HIFU is a possible answer. HIFU is an ultrasound probe that can create very high temperatures in different spots. And they were looking at potentially using that in this circumstance where they could go to where that little spot was in the bladder that I showed you and put some heat energy on there to try to ablate it. Again, not clear that this is going to be something that really takes off. There's a lot of structures in that area, like the ureters going into the bladder, that would make that very difficult too. So this guy says no thanks to radiation. So then what? We say, well, if you don't want to do radiation, our hands are kind of tied. We just basically keep an eye on it and see what happens. And when your PSA gets up high enough, we probably want to start some androgen deprivation therapy. Because if you see that PSA get super high, like 30 or 40, you can almost guarantee that there's pretty significant systemic involvement, and it may involve the bone, and it may be actually weakening the bone with time. And the number one complication we want to avoid from prostate cancer is fractures. Because as soon as you start dealing with fractures, then you're going to have mobility issues and things tend to go downhill from there. So we like to really be aware of the bone and protect the bone. So a bone scan is probably the most important thing to consider in this guy when his PSA gets up to 10 or 15. Is that on a bone scan we can see that there's disease there. We're going to want to start treatment and not wait any longer. Now, if you look at the doubling time of 6 months and where we were at there, you could count the years that this guy can go potentially before he's going to get up to these sorts of numbers. Probably like about 7 or 8 years when you think about it doubling every 6 months. So that's not bad for a cancer, you know, to have that kind of time just twiddling your thumbs and not worrying about it. But you ultimately have to intercept the disease. Now, in my own personal practice, I don't like numbers up in the 10 to 40 range. I typically intervene on this when it's around 5, just because if it's doubling and you get up to 20 and you turn your back or somebody goes on vacation or something like that, before you know it, it could be really high and there could be symptoms. So I like to kind of start intervening on this when it's closer to 5.
Yeah.
Yeah.
If it's 0.2 and he elects to have radiation, what are the chances that the problem is in the prostate gland and or not someplace else?
50-50. So in this guy, I mean, it's probably more likely that there is disease in the pelvis, but what you don't know is there also disease somewhere else, right? So this is the kind of guy where he could get radiation of the pelvis, and his PSA would drop down to say 0.02 or something like almost 0, and then 6 months later it's back up to 0.2, and it's because he's super high risk based on his pathology, and he probably has a node or two or something else that's somewhere else in the body and just hasn't manifested yet. So that's one of the difficulties with radiation. You seal off the pelvis and then you cross your fingers that there's nothing else somewhere else. So that not the lightest of subjects, I must admit. Trying to figure out where metastatic disease is always difficult for everybody. It's difficult for the doctors, it's extremely difficult for the patients and their families, because there's just so much stress about it, and there's this kind of belief that when I find where the disease is, we'll fix it, and a lot of the time that's not the case with prostate cancer, at least it hasn't been, because really there's only so much we can do surgically, and radiation has gotten a lot better. There's a new radiation technique called SABR, where it's like a very concentric beam that can target lymph nodes or very finite areas and not have to kind of blanket it. But knowing where to go has been the problem, because if you have a CAT scan, it could be just an enlarged lymph node, it could be prostate cancer, and we didn't really have technology to figure that out. Now enter the PSMA test. Has anybody here heard of PSMA PET CT? Yeah. 2 people? Yeah. So PSMA is prostate-specific membrane antigen. They found a molecule that's on the surface of prostate cancer cells. They named it almost PSA, which is great, so we can all get confused. But it's very specific, and they've now been able to develop an antibody that will attach to this membrane antigen specifically. So it will only attach to cancer cells in your body. Now we can attach things to antibodies. We can attach drugs, we can attach markers, radioactive markers, all sorts of things. So this is a big deal with prostate cancer. We've never really been able to single out prostate cancer cells from within your body before. And they started a program, it's just over a year ago in Vancouver, doing PSMA studies as a research thing, although in Germany they've been doing it for 8 years. Australia they've been doing it for about 3 years. And we're not really late to the game because there's a lot of places that still aren't doing it. It's a complicated test. They have to use the particle accelerator at UBC in Triumph to basically make the gallium appropriately to attach it to this antibody to get it to the PET scanner, and it has a half-life of 90 minutes. And that's what's going to be a big challenge for us doing this test in Victoria. It's going to have to come from Vancouver. It's radioactive, which I don't think is really good for air travel. And it's got to get here pretty much within a couple of hours of being made. They've also had issues with production because I guess this machine at Triumph is not totally reliable, and there's been times where they've actually had problems getting the material to keep the study going. They call it a study because that's how we get new technology here. Say, well, we're going to research it, but it's certainly not something that needs a whole lot more learning to realize the benefit that it has. So here's a picture of the PSMA molecule. And here, I don't know how well it makes out for you guys, it's pretty small, I'm sorry about that. You can see there's the antibody, this is the Y-shaped thing, and here we've attached some radioactive material to it. It's being taken up by the prostate cancer cells. And here you can see here's another picture of a similar antibody that's been tagged. And that's good news for imaging, but it's also good news for treatment.
How do you get it in there?
It's an intravenous injection. Yeah. So here is a PSMA PET scan from somebody that has pretty extensive disease. You can see basically the full skeleton here. You can see this is the aorta and the vena cava, and all these white lymph nodes are prostate cancer lymph nodes.
Wow.
So that's a lot of surgery to fix that. I don't think I'll be doing it. But there are cases where it's a little bit more simple. So here you have a patient that has a solitary lymph node. You can see here on the CAT scan how you can't really distinguish it from anything there. But after the PSMA injection, it lights up like a Christmas tree.
Wow. Wow.
So we have had some experience with this treatment here, or this diagnostic test now. I've had probably about 15 patients that have gone to Vancouver for the program. 2 of which have come back with solitary lymph nodes, despite having had a previous prostatectomy and treatment and lymph node positivity on this scan. And I've actually taken them for surgery to remove the lymph node, and their PSAs have gone from 0.6 and 0.45 respectively down to 0 post-operatively. So it's a really interesting time in prostate cancer because I don't understand that. I mean, I always thought of prostate cancer when it's metastatic, it's a big deal, and it's going to be in multiple places all at once. But perhaps when you think about the fact that some people get cured when they have a PSA recurrence by radiation alone to the pelvis, well, that to me suggests that there's disease in the pelvis, but it's nowhere else because they've been cured. So that's kind of the counter argument to saying, well, you've got metastatic disease, so you're going to be looking at hormone therapy. So as a diagnostic test, this is very useful. And going back to the staging, well, this test is very useful for staging because if you're coming in with prostate cancer and it looks like it's really aggressive, and we're going to suggest some sort of aggressive treatment, well, this is way more sensitive at identifying metastases than your bone scan and your CAT scan. They're only going to pick up things that are obvious. Plus, it's specific. So if you have a lymph node in your abdomen that's swollen, it could be because you've had a diarrhea attack or something like that, it's not going to light up. So we're going to have far more confidence that you're going to be a good candidate for treatment. So we're getting a PET scanner here in Victoria, hopefully this year, by the end of this year. And our goal, at least my goal, is going to be to try to promote getting access to this test as much as possible. Here's another example. This is Mr. Worst Case Scenario's follow-up image, and you can see he's got a solitary lymph node in the pelvis. And I won't make up the answer that we removed this and everything was fine, but it's possible that could be the scenario. Now, if we can attach gallium, which is what's used for PET scans, to this antibody, then why can't we attach something that's actually therapeutic? If we can isolate these prostate cancer cells in the body, why not put something else on there that's more, say, poisonous to the cells? Enter lutetium. So lutetium is it's a naturally occurring element. It can be combined with octreotide to attach it to antibodies, and it's a beta emitter. It has a half-life of about 6.5 days. When given during the PSMA study with the PSA, first of all, you light up like you do on the PSA scan, so you can actually go in the PET scanner after treatment, and we can see exactly where it's attached to. So if you have nodes here and here, we expect to see nodes here and here lighting up when you get this treatment done. After just 6.5 days, the radiation factor starts to dissipate, so it doesn't have a lot of long-term radiation-related side effects. If you look at the treatment side effects of this lutetium treatment, it's kind of laughable. Dry mouth, fatigue, nausea, and the nausea lasts, it's only in 1 in 10 people, it lasts for 48 hours. Compare that to hot flashes, that's not bad. You know, I think that doesn't sound bad. Now, if there's a lot of bone involvement, it can suppress the marrow because the marrow gets somewhat radiated from this, so that can be an issue if the disease is really advanced. Australia and Germany are the pioneers of this treatment, really. Germany's been doing it for about 8 years. Australia, like I said, it's about 3 years. I've got the first patient, I think, is going to go for it in September. The program in Australia is very user-friendly, so I contacted the program there. The guy, his name's Nat Lenzo, and he emailed me back right away. He set up a Skype interview with the patient, you know, within 2 days of me asking him to talk to him about this. Typically, the indication for this is for CRPC, or castrate-resistant prostate cancer. So you're on your ADT, your Lupron, or whatever ADT you're on your abiraterone or your enzalutamide, some of these advanced drugs, and your PSA is still going up. When you look at people that do this treatment in that circumstance where there's not a lot of other options out there, 70% of people respond to this. And the response can last longer than a year. Because it's private and it's in Australia right now, it's costing a round of treatment costs about 12,000 Australian dollars, which is about, I think it's about 10.5 Canadian. Most people want to start with 2 rounds of treatment, so you're looking at about $20,000 and a trip to Australia on top of that to get the treatment. There is a rumor that I heard, and there was something published by the cancer agency saying they're going to start trying to do this within the year here in BC for CRPC patients. Now, what interests me is not so much the CRPC patients, because that's a no-brainer. I mean, these patients are the ones that obviously don't have a lot of other options. And if you look at how all the prostate cancer drugs have gone, they start at the end and move forwards. You know, so before it was abiraterone was only for people that failed hormone therapy, and now we're starting abiraterone for people that just have bone mets. Same thing with chemotherapy. Chemotherapy was at the end. Now we're putting chemotherapy at the beginning, because we know when we hit the cancer harder, you know, you typically do better in the long term when you hit it harder in the beginning. So my question is, when you take your patient that has, say, 7 or 8 lymph nodes involved after their prostatectomy, so we still see a detectable PSA after prostatectomy, we see positive lymph nodes on the pathology. This PSA is, say, like 2 or 3 post-op. The PSMA study shows scattered lymph nodes in the abdomen more than we can deal with surgically. Should this patient be getting hormone therapy, or should they be getting lutetium right off the bat? Because this would, if they get this treatment, even though they're not CRPC and they don't qualify for it, we think that their likelihood of needing to start hormone therapy would be delayed potentially by 2 or 3 years, just from 1 or 2 rounds of treatment.
Could this treatment be repeated, say, annually, or if there's a progression?
Absolutely. So they say every 4 months they want another PSMA study to see what it looks like and decide on that. But the thing is, like, in a PSMA study-rich environment, like Australia, they've got 12 scanners or something like that in Sydney. They can do that. I think we have to rely more on PSA as being the surrogate, you know? So if someone's PSA is 0, you don't need to do it, you know? But if their PSA starts creeping upwards, I don't really know that you need another study to justify it. But my guess is that it may be replacing hormone therapy in a lot of people, or at least pushing it down the road. And I have a few slides here about hormone therapy. Oh yeah, so here's this lutetium treatment. 70% of men that get this treatment, and this is in the CRPC, no other option category, that 70% of men are having PSA decreased by greater than 50%. 20 to 30% people have a complete response. So you'll go from having a PSA of 25 on hormone therapy, on enzalutamide, get this treatment, and your PSA goes down to 0. And most people that have had the treatment are lasting longer than 13 months before they're showing signs of progressing again. So it's a big deal.
The ADT is expensive too.
It is, absolutely. I mean, if you can get away with no ADT for a year, and this costs $12,000, that's roughly equivalent. And it's not the ADT that's expensive. This is expensive. These guys, abiraterone, enzalutamide, radium-223, apalutamide, the cost is insane. I mean, we're talking about $6,000 a month for some of these drugs. Oh yeah, they're pricey. They're very pricey. So this is again a slide from my old slide set there. I'm talking about ADT and saying it's not working. I thought I'd just explain some of these drugs again, because I don't know if you guys are having to deal with some of these drugs, but they all have sort of logic behind them and different mechanisms. So I'll just spend a couple of minutes talking about this, just in case it stimulates any discussion or questions. So abiraterone, this drug is a drug that is designed to block testosterone production. Now, ADT, so typical ADT will shut down your brain's ability to tell your testicles to make testosterone. And that usually will get the testosterone levels down low. We like to see these numbers less than 0.5. But what the tumor does is the tumor actually goes back to the lab and starts doing experiments in the deep DNA, where it's pulling out genetic material and looking at it and trying to figure out where the testosterone synthesis data is, or like the blueprint, right? And eventually, prostate cancer cells will start just making their own testosterone. So we take it away from the outside, but the testosterone will actually start getting produced on the inside. Fascinating, you know, like there's like a 21-step process to make testosterone, you know, and these cells will figure out how to do it eventually. So what abiraterone does is it actually blocks the production of the building blocks for testosterone. So it takes away it blocks the precursors of testosterone from being converted into the building blocks for testosterone. I think that's very fascinating, and because of that, you have a shutdown of basically your ability to make steroids. We can't live without cortisol in our blood, so we have to replace the mineralocorticoid deprivation that we get from blocking steroid synthesis. But it's quite effective, and this is an interesting drug because since I gave that talk last, there's been a new study that's come out looking at people that take, say you have a new diagnosis of prostate cancer with bone involvement, high PSA, high PSAs of 500 or something like that. The studies have shown that if you go on this drug with your ADT right off the bat, that you'll usually have a fairly substantially elongated period of time before your PSA will start going up. So this is a study out of London. And there's a couple of studies like this, including a study using chemotherapy in the same way. Right off the bat, when you get started on ADT, you go for chemotherapy, and we see that the change to being androgen independent is a longer period of time before you get there. Abiraterone is probably easier to tolerate than chemotherapy. It's way more expensive, but it's probably more easy to tolerate. You have to take prednisone with it, which is a drug that can affect your, sorry, I'm turning my back on you guys again. It's a drug that can basically make you puffy and it can affect your sleep and your thought process and that kind of stuff. So there's side effects from it that can be substantial. But if someone asked me, you know, what's your preference over taking abiraterone with prednisone or getting chemotherapy, I'd probably take the abiraterone just because it's easier to tolerate. Now, what they didn't look at was people that were on hormone therapy alone, and then the PSA started to go up, and then they started abiraterone, and compare them to the people that were taking both right out of the gates. But we still think that both right out of the gates might be better. And you have to have a substantial disease burden for that to make sense, and you also have to start it fairly early into the cycle of androgen deprivation therapy. So if you've been on androgen deprivation therapy for 6 months or longer, there's no point in adding this drug if you're well suppressed. Everybody follow me still? Sorry, I'm saying so much information here. I can't believe it. You guys can possibly absorb all this. This is like everything I know about prostate cancer in 45 minutes. I'm going to be totally tapped out. Enzalutamide is another drug that's in this sort of like fancy prostate cancer drug category, typically reserved for people that have failed androgen deprivation therapy. not currently being used early into treatment like the abiraterone is, but it probably should be, because we think that, you know, the more we hit the disease up front, the more it, you know, the longer you can get away with not needing more treatment. This is basically an androgen receptor blocker. Androgen receptor is the thing that testosterone is telling to go to the nucleus to tell the cells to replicate. So enzalutamide not only blocks the testosterone from attaching to the receptor, but it blocks the receptor from translocating into the nucleus where it's going to give the signal. And then if it does get in the nucleus, it also blocks it from telling the DNA that it's being stimulated. So it's an interesting drug on that sort of ideal that it does more than one thing, but it's highly effective at shutting down prostate cancer. And I've been blown away by my patients that have ended up on this drug where there's really hasn't been a lot of alternatives put forward, and they start this drug and they're having years and years of quality life. Side effects seem to be like they're very minimal. You don't have to take prednisone when you take it. And I just look at this whole population of patients that I have on this drug right now that wouldn't be here without it. It's been a real game changer for prostate cancer, and certainly a welcome addition to the army of different things we're doing. Now, radium-223 is one other thing I'll just mention. We don't, as urologists, we don't prescribe this. It's mainly the radiation doctors, the radiation oncologists that prescribe it. But what it does is it sort of finds its way into nests of prostate cancer cells that are within the bone. It sticks there and it emits radiation to those areas selectively. So it can kind of cover a large area. We typically only use this for people that have CRPC, so they're basically having PSAs that are going up and they have bone involvement that we think is substantial. And again, it's all about protecting the bone. And new horizons. So immunotherapy is something that we've talked a lot about, and the problem with prostate cancer and immunotherapy is it seems like there's just too many variations of the cancer to really nail it with one form of immunotherapy. And just yesterday there was a publication put out about trying to sequence the DNA of the cancer and trying to find various immunotherapies that will be effective, because we know it works, but we just don't know which cancer it's going to work well for. So on the horizon, there'll probably be some sort of immunotherapy once we can figure out which cancers are going to be the best responders. So do you have a perspective?
We have apalutamide on there, and you didn't talk about it.
Oh yeah, so apalutamide, yeah, sorry, I didn't have a slide for that. Apalutamide is anything that ends with amide is a blocker. So it's basically a knockoff of enzalutamide. It does the same idea. Now, that drug is an interesting drug because it just got approval this year. It's a Janssen drug, and because enzalutamide's filled such a big gap, what they've done with this drug right out of the gates is they've targeted the M0 population. So M0 is basically means that you have a PSA that's going up, but all of the studies that you've had done have never really shown where it's coming from. And the other interesting thing about M0 is that with PSMA studies, M0 is about to not exist anymore, because we're going to be able to identify where PSA is being produced for just about everybody. And they've marketed this drug now saying that if you have CRPC, so your PSA is going up, your imaging is negative for where it's coming from. There's a lot of people in this category. Enzalutamide never really was tested in that category. Abiraterone, same thing. Like M0 was always for people with metastatic disease or like bona fide metastatic disease, where you can see it on a bone scan. Apalutamide, they say, if you're in this M0 category, we're just going to give you the drug. Just take it. It's free.
Why?
And that's how they're marketing it. I think they're trying to gain market share against enzalutamide. And they basically looked at it in a completely different disease frame. Like I can tell you that if you have prostate cancer and you start ADT, if you start ADT and enzalutamide together, your PSA is going to crash, and you're probably going to go on for a really long time before it becomes a problem. So if you started another drug like apalutamide, same thing, right? The earlier you started, the better. So because the drug, this is a complicated subject, I'm trying to summarize it, I'm probably not going to do a good job, but because they have to show that these drugs are doing something, they really have to look at people with bone metastases or something that's visible and say, there was something there, we gave you this treatment, and it's gone. These are the people that are easy to prove that drugs working. M0 is difficult because it's all about PSA. there's no actual hard findings to prove that it works. But it does, and we know that these drugs are going to be better than nothing at the very least. So I think to gain market share, they had to look at something that hasn't been looked at before to get it off the ground. And then they just start throwing it out there to get people, I guess, experienced with it and using it. And then they're going to say, oh, hey, by the way, this also is $5 cheaper than this other one, and it works the same way. So, you should start using it there too. But that's just the marketing strategy I understand that they've used to do it. Yes?
Can you comment on olaparib? PARP inhibitor.
Yeah.
Lynparza?
Yeah, for prostate cancer?
Yes.
Yeah, I've got no experience with that. Yeah. That's a part of the immunotherapy family, right?
Yeah, it's for people who are positive for the BRCA2 gene.
Right.
And have prostate cancer.
Yeah. I'm sorry, I have no experience with that. Yeah.
You mentioned the high cost of these drugs.
Yeah.
If they become generic in, say, so many years and become quite reasonable, is that in the future?
Yeah, it's a ways off. Yeah, it's a ways off. Like, I think abiraterone is the first drug that will go generic, but I believe it's still like 5 to 10 years in the horizon. Somebody told me how long it was, and I was surprised at how far off it was recently. Yeah. Yeah.
With this, I don't know how to pronounce it, the one you're just discussing here,
Apalutamide?
Yeah, apalutamide.
Yeah.
If it's inexpensive, could you use that instead of like Zoloft or the other ATT?
No. So none of these drugs are approved to be used without concurrent ADT. And that being said, like the side effect profile is roughly the same. For testosterone blockers, it's maybe not identical, but first of all, when I say this drug's free, I'm talking about a very select group of patients, right? You have M0 CRPC patients. CRPC means you've been through androgen deprivation therapy for like, 4 to 10 years, 2 to 10 years, it varies, but you've been through that treatment and it's not working. That's when they'll give you the drug. That's actually the only time the drug's approved. We just know that it's going to work at earlier stages. And as a surgeon, the lion's share of the prostate cancer I deal with is earlier stage. Most of the medical oncologists are the ones that are prescribing these drugs.
But it would work just as well, but it's they're going to use Zoloft for other things. Really.
So Zoladex, I think is what you're referring to. Yeah, there's no real rationale for using any of these drugs without suppressing testosterone. If you, just to answer that question more clearly, so if you use any drug that blocks the testosterone receptor, the androgen receptor, but you still provide testosterone, what happens is cells typically upregulate the production of the androgen receptor. So instead of the cells just having 1 or 2 androgen receptors, they'll just make the whole membrane covered in androgen receptors. So you'll have to keep blocking more and more with time. So you can take this drug Casodex or bicalutamide at high dose instead of ADT, but only for a period of time, because eventually it'll actually exacerbate the cancer. The cells will get so many androgen receptors on them that as soon as they see testosterone, they'll go crazy. That's sort of conventional theory, but if you use a really high dose of it, like 150 milligrams daily of bicalutamide or Casodex, you can usually pull off a period, sometimes up to a year and a half. Some people are doing this now for external beam radiation therapy instead of taking ADT, but you get pretty substantial side effects from that as well. It causes gynecomastia or breast growth, and it can cause liver damage as well. Yes?
Do I understand correctly that the PSMA diagnosis is available in Vancouver now?
That's correct. Yeah, it's a study. It's taking about 7 months to get the test done. I've had conversations with them in Vancouver, basically proclaiming this is inadequate. And I know that there's some funding that's trying to be amassed they were only going to do 200 patients. I think they filled that quota pretty quickly, and they just expanded it to, I think, 1,000 or something far more substantial. But they still can only get through a few people a day with the test, so it's not easy to get people through. Now, there's a private PET-CT scanner in Vancouver, PET bcpet.ca or something is the website. I've talked to them, and they're trying to get the gallium from Triumph so that they can run it as well privately.
You can only get it from Triumph.
Yeah, because the half-life is so short, I don't think they can import it from somewhere else, effectively. Now for getting this test done, just to be clear, so I've pretty much given up on doing this, and most of my patients have gone to LA to do it. So LA, they'll usually organize it for you within about 2 weeks. It costs $2,700 US to do it. The cost of this stuff is not cheap either, though. They're not making money for that much money. They do the test, they send me a disc the next day through FedEx, and they send me a report right away, like by email. The reports are very useful. They're very elaborate. They've got tons of experience doing PSMA at UCLA. Now, you could do it cheaper if you wanted to in Australia. So the Australians will do it for 1,000 Australian dollars. You just got to get there. And also very quickly, not the 7 months. I mean, the problem that we have is we're trying to decide whether people are going to go get pelvic radiation. And so we want them to go for the PSMA PET scan to see if we can see a node or something there that's maybe treatable or doesn't require pelvic radiation. And 7 months is not adequate. Like, we can't sit around for 7 months and twiddle our thumbs while we don't know what the next step is.
Yeah, I'd like to know if bipolar androgen deprivation, bipolar androgen therapy.
Bipolar
Yeah.
androgen therapy?
Yeah.
I'm not familiar with what that is.
Let me just finish the question, and then would be a good option for somebody with long-standing hypogonadism and rising PSA.
Okay.
And what the bipolar androgen therapy basically is that you go on ADT, and then once a month you get a huge shot of testosterone, which destroys the extra receptors on the cell.
Right. Yeah.
So
I'm sure there's data about doing that. I'm not really familiar. I don't have patients that are doing that, but I've often wondered whether it makes sense to do that. Or perhaps, the thought of, castration, surgical castration is still a very viable option for a lot of people, where you can get the testosterone down to zero.
That wouldn't really be quite an option if you have hypogonadism. If you're
The problem with hypogonadism is you need zero testosterone, right?
Yeah.
So even hypogonadism may not be enough to get really suppressed levels of testosterone.
Yeah.
But yeah, I think that there's a lot of people that benefit from that, because when we do intermittent therapy, we usually let the testosterone get up back to normal. It just takes a long time. And it can be frustrating for patients waiting that long to do it. The one thing though is if you supplement testosterone, your body's natural ability to make it is going to be like zero, right? So that's where things get complicated too, is if you lose patients and say, let's supplement the testosterone because it's taking too long to come back, you're going to be on it forever because your natural ability shuts down as soon as it sees testosterone from somewhere else. But yeah, I think it's a reasonable thought. It's got to be disease specific too. I don't think you can say that's for everybody, particularly if you have bone involvement. If there's bone involvement, then forget it.
So in other words, the bipolar androgen therapy is not an approved therapy here.
I don't think anyone's doing it.
No.
Yeah.
Okay.
Approval doesn't really mean anything for us. We kind of shoot from the hip. But yeah, with respect to an actual program for that, I'm not familiar with it. It wouldn't surprise me if it's a European thing or something like that, but I'm not familiar.
Thank you.
Yeah, in the back.
Just going back on your talk, that the previous speaker at one point indicated that rising PSA wasn't important until it reached about what? I mean, the doubling time. Comment on that?
The doubling time doesn't matter until it reaches.
Well,
Could you repeat the question?
wasn't
Yeah.
significant until it was at least what? The PSA had reached what?
Right. So the question is, the doubling time does not become relevant until the PSA gets up to 1. And my response to that would be, it depends on what scenario you're talking about. So if you're talking about radical prostatectomy, where we expect the number to be 0, that's way higher than I would expect you to wait to know that. So I would say less than 0.05 those numbers are very difficult to interpret. But once you get above 0.05 to about 0.2, you can start to calculate the doubling time in that range. Now, after radiation treatment, depending on what type of radiation treatment it was and where the PSA, we call it nadir, or sort of flatlined after treatment, for some people that number might be 0.5 or 0.7. That might be as low as you get after radiation treatment. And so a doubling time in that circumstance might be very difficult to calculate, and you need the numbers to be higher to do so. But for post-prostatectomy, absolutely not. You can start calculating that when the numbers get up to around 0.1 or 0.15, 0.15.
At what point, at what level of PSA should someone go back for treatment?
Well, I was talking about that in one of those slides where I said, you know, the dogma sort of says between PSAs of 10 to 40 are where we think you should intercept the disease with ADT. That's been sort of traditionally what's believed. In my personal opinion, it depends on people's age and general health, but I typically intercept numbers of around 5 if I'm convinced there's disease there. Now, another thing I was going to say about the M0 category, where things get really interesting, is so we're doing all these studies to try to take people out of the M0 category and know where their disease is. I don't know that it really helps everybody to know that, but I'm like a knowledge seeker, so I like to try to sleuth out where their PSA is coming from. And if you find that it's coming from the bone, that's probably a big help, or you may have saved them a lot of morbidity, because you don't really want to wait on bone disease to treat it. Now, the problem is that this drug company just came and said, we're going to give you this super expensive drug for free, but only if you're in that M0 category. So here I've been taking patients out of the M0 category, you know, and all I've done is basically taken away their ability to get access to this drug by doing that. So there's all these sort of pros and cons that exist out there. I didn't talk about this, but for PSMA testing, there's sensitivity issues. So we look at the PSA test and say, how low a PSA can we actually find something on a PSMA study? So at around 0.1 of a PSA, so we're talking pretty low, 0.1, there's still a handful of people that will get picked up. So I'd say it's maybe between 10 and 20% likely that we'll see something like a node on a PSMA study. If you get up to 0.2, you're looking at about 50% of people where there's going to be something detectable. And when you get to 0.4, it's closer to 70% of people. It's pretty substantial numbers. There's actually, the UCLA's just funded a study to look at anybody with a PSA over 0.1 that is trying to contemplate whether they want to get radiation therapy done. The reason that it's relevant in that circumstance is because if you go and get that PSMA study done and it shows you got a lymph node that's, you know, under your diaphragm or something like that, radiation may not be the best treatment for you, right? So you can sometimes take people out of the radiation treatment group. Yeah, it may not be the right answer, but it's definitely information that may change the game. So that research study is actually funded. So you have to pay for your travel to go down there and do it. You have to there's a few qualifiers for it as well. But they just need to know if you're contemplating getting radiation therapy and they send you down for this test, does it change the desired outcome or the desired treatment? And it's funded for that. So we're on the lookout for these patients now. Yes?
Yeah. How do you decide whether to prescribe, say, Lupron or the Garelix?
That's a good question. It varies. There's a whole bunch of different reasons. For instance, like Lupron is a shot in the butt, and for patients that come in a wheelchair or something where they have decreased mobility, it's not usually a great option because it's inconvenient. Zolotix is a very easy drug to administer. It has minimal side effects from the injection itself, but it's a 3-month injection, whereas Lupron you can get a 4-month injection. The Garelix has a very quick onset. That's one of the benefits that it has, and it also has a very quick offset. So when you stop taking it, it tends to wear off quicker. So if somebody wants just 3 months of treatment, or it's going to be really short, I'll often use that drug because I know it wears off quickly. It has a much worse site reaction, so you typically get big bee stings where the injection goes in and it can bother you for a few days, sometimes even a week or so. You can hear groaning. They know what's up. Yeah. So yeah, it's sort of a, none of the drugs have been proven to be more effective than the others. One other thing that's nice about Dagerlex is that it doesn't require the use of Casodex at the same time. So it's one injection, it's actually 2 injections, the first dose, but you don't have to take pills. Whereas Zoladex and Casodex, typically you take it with pills for the first little while. Those pills are designed to suppress the testosterone that is created by giving the injection in the first place. Yes?
You started off your presentation by saying that in your view there's 2 stages. You do surgery, and if the PSA is 0 after surgery, you're cured. If it's not cured and you go 1, that's stage 2. And then you went into all these wonderful new things. But each one of them, I heard you say, all they do is control it for a while because eventually your PSA is coming back. Is that true, or did I misunderstand that you can, once you have surgery and your PSA is not 0, all you're going to do is delay it from coming back? Do you have patients who have, you can say, are cancer-free by taking one of these other treatments, or did I misunderstand it?
So the question is, if you have a recurrence after a definitive treatment like prostatectomy, say, PSA starts going up, is there a cure for that situation? And the answer is hormone therapy, radium-223, abiraterone, apalutamide, you name it. These are all designed to suppress the disease. They don't cure it. Lutetium may cure it. It may, but we don't really know. Like we don't have the experience, and we have some complete responders, but the median time that it seems to suppress things is about 13 months. But it's completely different. It's a completely different treatment than hormone therapy, so we don't know when that treatment is going to expire or not continue to work. And for some people, it doesn't work at all. There's about 20% of people that have prostate cancer where a PSMA study will show nothing for just about ever, because they just don't express the PSMA molecule that sits on the surface there. So those people won't respond to lutetium either. Now, where the stages get fuzzy is the intermediate stage where you have disease in the prostate and around the prostate, and we can either surgerize all the disease that's there or radiate it. And there's got to be people that are cured in that circumstance, because when you have, say, a really low-grade PSA recurrence post-prostatectomy and you get external beam radiation therapy done, there's about a 50% chance of cure with that. So radiation can be curative if you have a PSA recurrence after surgery. With PSMA studies, I don't know if you would know this, but occasionally we'll find things that we can chase after, and apparently the literature on this is not great. Like the likelihood of recurrence after you remove a positive lymph node, even if you see a 0 PSA, is still very substantial. But I do believe that there's going to be patients out there where the disease is limited. We can actually identify the extent of it and go in there and clean it out. And that leads into another discussion, which is, if I have metastatic disease, so say I've got my PSMA PET study done, and it shows that I've got a lymph node that looks like it's above the field of radiation, do I have a prostatectomy done? Is there a point in taking out the mothership of where the tumor is if you can't get all of the rest of the disease? And I'd like to tell you that absolutely you should, because that's what my instincts tell me. The data is still somewhat skewed, but we do believe that when you see that guy with the PSMA study that had, just oodles of disease versus the guy that has like 8 lymph nodes, you're probably gonna do better when you have 8 lymph nodes versus all that disease, because the PSMA is gonna have more ability to concentrate on the areas that need it and not get sort of diffused or scattered. So by that logic, if that's gonna become the standard of care for treatment, the less disease you have, usually the better off you're gonna do. So there's probably a lot of logic in this day and age to have a prostatectomy done. If we can get a PSMA study and know where those nodes are, it's very possible we can take the nodes out at the same time, and then we just cross our fingers. But that's about all I can say. None of these androgen, anything related to androgen is temporary. It's not gonna work forever. Maybe there's the occasional person that does it better than that, but in general. So, yes?
At what point do you move your patients over to an oncologist? In other words, you've done your best and
So with the advent of the upfront treatments like abiraterone and chemotherapy, I send everybody to see a medical oncologist, just about right away at the time of diagnosis. Because if you're, like, I can't always tell who's a candidate and who's not, because they keep moving the goalposts. So I like to get everybody at least assessed, and that way you're connected to somebody there too in the future if there's problems. Yeah, so I think seeing a medical oncologist is helpful. Now, if you're already on androgen deprivation therapy and it's working fine, you don't really need to. But to know candidacy for various trials and studies that are out, I usually will defer to them for that. Yeah, that's right. Last question.
Yeah. I was diagnosed 9 years ago, and I was put on ADT immediately after the prostatectomy.
Yeah.
And I, at one point, started to get some reoccurrence in a couple of lymph nodes. And the oncologist actively blocked me to go and get surgery to have those lymph nodes removed. And since then, it has spread to the point that now it's all over the place. But their rationale was that surgery was a waste of time because it was already systemic disease. This is as recent as 2 years ago.
Yeah.
So I found that they were not helpful at all. They wanted to do their thing, which was give pills. They didn't seem to want to talk to anybody else. So has that attitude changed at all, or do you find that?
Well, I feel for you, because it's never nice to sort of feel like things are being withheld. That's not something I really like to hear from any of my patients, Based on what you told me, I mean, it sounds like there probably wasn't really a great role for surgery there. I mean, surgery typically has to be one specific spot, and 2 years ago we wouldn't be able to pinpoint it like that. So, we're funneling, 100% of the prostate cancer patients down to 1% where we're finding something that's surgery able. Most people are going to have disease that's beyond what can be done surgically. Now, lutetium, for instance, is something you might want to look into, because this treatment should, as long as you got PSA in your blood, you're gonna respond to that treatment. Typically, maybe there's exceptions.
Yeah, I'm currently on an olaparib.
Oh, okay, there you go. Yeah. Olaparib? Olaparib. Yeah. That's I don't know a lot of people on that medication, I can tell you that. I think you're the only one, yeah, for sure. Well, it's nice to meet you. But there are definitely some horizons out there that may be helpful in the future, but it doesn't sound to me like surgery would be great. Now, what I was just going to say is a sort of closing argument is that we have now started, we actually work very well together between the radiation oncologist and the medical oncologist. It may not come across that way because there's often communication issues between offices and whatnot, but we meet twice a month, all of us, at a table for an hour, and we go through all the cases that we need collaboration on. It sounds like, if we had been doing this 2 years ago, that might have been a good thing to discuss, if that was a question you had. But I think that it's within your all prerogatives to see whoever's looking after you and say, I'd like you to conference this and tell me what your colleagues think. I don't think that's a problem to ask for that. And, we often whisk through things because a lot of them fit into templates or sort of more cookie cutter type answers. Some of them are more complicated, and it sounds like with your background and the need for that drug and stuff that you're probably the kind of person we'd like to discuss because we could all learn something. So that's one way you guys can mitigate that, is to ask for things to go to conference.
So, thank you very much. I think I was glad to hear tell you from 10 years ago, the things that are done now, what's pursued, where the suspicions are, and all that, and all the complexity of the cases today. There's just so many more opportunities for you to benefit. So you've been fantastic tonight. We really appreciate it. Thanks very much. Dr. McCracken.